Thank you, Martha. Hi, everybody. It is my pleasure and honor to share with you our experience with PrEP TPC, which stands for Preventing Readmissions Through Effective Partnerships, Communication, and Palliative Care. And this is really an example of a program that seeks to move generalist palliative care knowledge from knowledge to outcomes and culture change within institutions. The one message I will continue to echo throughout my portion of this talk is that it is not enough to simply teach the skills of generalist palliative care. We have to think about how we are affecting and changing the system. And we'll go through that with our experience over the last couple of years. To give everybody a background, PrEP CPC is actually a suite, it's part of a suite of different interventions that is a statewide initiative designed to try to re-engineer transitions in care and address Illinois' high readmission rate. The key is collaboration between Northwestern, Blue Cross Blue Shield of Illinois, the Illinois Hospital Association, and the Society of Hospital Medicine. 85% of the 218 hospitals across the state of Illinois participated in at least one of the PrEP projects. So it was truly statewide and allowed us to see what kind of an impact this sort of intervention had. The project goal of TPC, the focus is really to help non-specialty trained clinicians from hospitals across the state to improve competence and confidence in facilitating goals of care conversations and translating those conversations into meaningful care plans. In line with the overall goals of the PrEP program, we set two outcomes for hospital teams to focus on. One was 30-day readmission rates for a particular illness. Two was increasing documentation of goals of care conversations and advanced directives. Our real focus was on objective number 2 because we weren't sure that objective number 1 could be attained within 1 year by focusing just on communication skills. There are 3 key assumptions that underlied our effort. Number 1 was that communication skills can be taught and learned. But again, simply teaching the skills is not enough to affect patient outcomes or systems of care change. Focus needs to be on changing the system of providing care, and we assumed that teams needed some support throughout the year in driving change. And we, of course, assumed that we did not have all the answers and that we were going to use this experience to learn a little bit more about how to do this sort of work. This is the general framework of the intervention, again, showing that teaching generalist skills is not enough to drive change. There are 4 key steps in the process. 1, as Martha mentioned, was identifying patients with unmet palliative care needs. 2, ensuring timely and competent goals of care conversations and documentation. 3, coordinating care with post-acute care partners. And 4, respecting the process, knowing that adjusting goals and plans of care as patients change and as they receive care in different sites of care, that these communication, these discussions had to be revisited over time and plans of care adjusted as we went along. This model is really just gives you the sense of what a year-long process in PrEP CPC looks like, although it's not at all to scale. The teaching skills is a crucial but actually a relatively small part of the intervention. The bulk of the work is actually in the 4th box, where we figure out how to embed the skills in practice and influence other colleagues within the institution or system to partner together. I'll spend a little bit of time talking about our training program because I think this is important. Teaching skills, again, is not enough to drive the change, but without a solid foundation of generalist palliative care communication skills, patient outcomes are unlikely to be realized. So we use multiple modalities to teach, practice, and refine goals of care communication skills, which was really inspired by other successful communication skill training programs like OncoTalk and PalliTalk. And you'll see that here. You can refer to this at any point when you download the slides. The hallmark of our training is really being able to have participants practice and receive focused feedback from trained facilitators and faculty. And this is one of our faculty members, Boye Ogunsetan, who is watching and preparing to give feedback to a participant who is interacting with a standardized patient in our simulation center. The second day of our kickoff training was really focused on quality improvement projects. It was really important that the teams undergo skills training first so that they could appreciate what would be needed in terms of their intervention. But then they spent the second day trying to figure out how they were going to implement change at their own home institutions and influence their colleagues when they got back home. Again, as I mentioned, most of the year was spent trying to implement and refine quality improvement projects around goals of care communication for patients with serious illness. And that took the form of three things. One is regular phone check-ins for guidance and project adjustment. Two is in-person site visit by faculty. And three was reporting to and receiving feedback from other teams in a given cohort. As you can see, this is a pictorial representation of the year with regular conference calls, a mid-year all-group webinar, a mentored site visit, and a chance for us to reunite at the end of the year to share our experiences. What emerged from this process and from the way we set this up was it was very clear that this was truly a process of ongoing change and refinement. None of the teams ended up with a project that they thought they were going to do at the beginning, number one. But the other part that was really interesting and really helpful for all of us was that sharing with others throughout the year and at the end of the year really helped us build a community around shared intentions and shared attempts at change, which was really great for us as faculty, but also for all of the participants too, to know that they weren't alone in trying to create change. Just to give you a sense of who our participating hospitals and learners were, we had 29 hospitals in all that comprised 6 cohorts, or 6 different rounds of PrEP CPC. About half of those hospitals were in the greater Chicagoland area. The rest were downstate. And the participants, this is a slide that shows you who the participants was. I think it's important to note a few things. One, most of the learners were not physicians. Two, most of the learners were not palliative care practitioners. They were inpatient nurses, case managers, heart failure clinic nurses, hospital chaplains, none of whom were specialty palliative care trained or work within a specialist palliative care team. The other thing to note is the core teams of intervention, when people went back to their institutions, were comprised of additional people who did not necessarily attend the training conferences. So we encouraged teams to go back and teach their colleagues. We also encouraged teams to include physician champions, but many of the teams were led by nurses or social workers. This is a slide that gives us a sense of our effect in terms of learners' confidence to carry out many complex conversations having to do with serious illness. And we met one of our aims in that the participants left the program feeling more confident in facilitating important conversations about serious illness. But again, this by itself is not enough to drive change. The next goal was about seeing process change, and we're pleased to say that we saw that as well. we see, number one, that participants went back and helped spread some of these skills across the institution to other colleagues. Two, there were systematic changes to identify patients with unmet palliative care needs and initiate conversations, and virtually every group created new systems to do that. And three, all systems created a documentation system to capture and share these conversations, not only within the hospital or the institution, but also with their post-acute care partners. What we were lacking a little bit, as you'll see on the right-hand part of the slide, is across the board, coordination of care with post-acute care partners didn't happen as much as probably should have. So if we were to summarize the outcomes, people found it useful and enjoyable. Participants left more confident. They taught more of their colleagues to do this sort of this work. They developed new processes within their institutions to carry the change forward. And in the end, they actually documented increasing numbers of goals of care conversations, all the things that we were hoping for. One of the subtle things, and I think greatest thing that came from this project, are all the unintended or semi-intended palliative care ripple effects that came from the project. One was an increase in education and conversations about the benefits of palliative care amongst other practitioners and executives within these hospital systems. People were talking about palliative care in a positive way and how it could benefit the overall aims of the institution. Two, it actually got palliative care embedded into system strategic goals and strategic planning. Three, it inspired some systems to invest in specialist level palliative care because they could see the benefit and they realized that they needed to invest in a specialty level of palliative care where they had not been there before. And four, teams engaged their own communities outside of the hospital and in some ways normalized the conversation about serious illness and palliative care in a way that made discussing palliative care and end-of-life care much more normal. And we thought that was really, really exciting. Now, the other thing, as we said, one of our outcomes was looking at 30-day readmission rates. We didn't know what we were going to find. And I will say that this is data shared by the Illinois Hospital Association that showed that over the time of this project, and again, remember that all the PrEP projects were going on around the same time, 30-day readmission rates for potentially preventable readmissions decreased across the state. And specifically for those groups that participated in PrEP CPC, and we only have data for the first 3 cohorts, that readmission rate also dropped. And for some hospitals, dropped much lower than the rest of the state. Having said that, we also noticed that some of our teams did not show a decrease in readmission rates or had more trouble implementing systemic change, and we wanted to use those hospitals as an opportunity to learn from that. And I think, again, what we learned was that some of the teams did not, could not show a benefit because they didn't have enough time, or the scope of their project and their intervention was too small. It is possible that the conversations they were having were ineffective. Lack of physician engagement was a common theme across the board and may have stunted some of the impact that these projects had. And again, I mentioned that not all the sites focus on coordinating care across sites of care, and I'll speak to that a little bit more later in a few slides. We also thought it would be helpful to just share one example, one of our hospitals, to give you a sense of what they did and how that led to change at their institution. Hospital A wanted to focus on readmissions for patients with heart failure. And what they did was develop triggers to identify patients who potentially could have unmet palliative care needs and who could benefit from an open goals of care conversation. they trained transition coach nurses, in addition to home health nurses and heart failure program nurses, to initiate these conversations and carry them forward over potentially multiple visits. And then they developed a system for documenting goals of care conversations for all identified patients. What they noted was a dramatic decrease in their heart failure 30-day readmission rates over a year, actually. And they went from about 30% 30-day readmission rates down to under 20%. And they attribute that to not only having these conversations and matching the right care to the right patient at the right time, but also coordinating that care across those different sites. And you'll see here in this slide that they had a dramatic impact on heart failure, where they didn't apply the intervention as closely. They didn't see as much of a change, and they were encouraged by that. So what worked for Hospital A and Y? Number one, they had a dynamic team and project leader that kept people on task and helped the team really focus on rapid cycle quality improvement, so that when things weren't quite working, they addressed it and they changed it quickly and they didn't wait. Two is they really did partner with other QI projects that were focused on readmissions and on transitions in care, and they looked for a way to synergize. Three, they identified responsible champions. So, for example, the heart failure nurses in clinic and the transition coaches who would take on as their responsibility to carry out some of these conversations and make sure that the outcomes of those conversations get passed on to the primary care physician or the cardiologist or the next site of care. And again, they really focus on collaboration between sites of care.